Thank you so much, Roxanne. So I just thought that maybe I'll try to make it a little bit controversial rather than say that it should be done for everybody. The question is, should it be the standard of care, or do we actually need a randomized clinical trial? These are my disclosures. So, what are some of the other interesting trials besides bicuspid? And of course, we need a trial in aortic regurgitation, failed surgical bioprosthetic valves, mixed valvular heart disease, and failed TAVR valves, right? Surgery versus TAVR. But I think that this is particularly important in bicuspids. And I think that's because, these are my 5 key arguments, bicuspid AS will be encountered with greater frequency as TAVR use expands in younger patients. Almost 50% of the surgical aortic valve replacement in the young are actually bicuspid. The available observational data are limited by treatment bias. Perhaps only favorable anatomies were treated. Surgical outcomes in young bicuspid AS patients are excellent. So it's reasonable to expect robust evidence for TAVR to replace SAVR. Anatomically, it's a heterogeneous group with frequent aortopathy, and unlike what has been treated in previous IDE studies. And the precedent for label expansion in TAVR in the last decade has been IDE randomized clinical trials. So why make an exception now? All right, doesn't seem like an interventional cardiologist, but I think, so the question is, so is low-risk bicuspid AS, is TAVR equal to SAVR in this, So of course we know that in low-risk trials, TAVR was equal or better than SAVR, and we've got some data from the TVT registry where 1-year death and stroke was similar in bicuspid AS and tricuspid AS. So can you make that, can you infer, can you actually say that that is what should be done? Now, this slide was shown earlier. In fact, if you look at the distribution of bicuspid aortic stenosis, it's actually substantial. It's almost 60-70% when you're looking at some of the patients where we tend to be moving in the future. In fact, in this same study, where in more than almost 1,000 patients done by Bill Roberts in the operatively excised valves, almost 50% of the patients undergoing surgical aortic valve replacement were bicuspid. But then when you look at the TAVR registries, that's not what you see. So some of these registries, the number of patients undergoing or having bicuspid aortic stenosis is like in single digits. So I think there is something different about the patients that we are doing TAVR in. And of course, these are all these randomized clinical trials that formed the basis for approval, whether it was inoperable, high risk, intermediate risk, and low risk. So the question is, should we actually expect the same? Because if you look at the key anatomical exclusion criteria, bicuspid valve was excluded from all of these studies that I actually showed you. So what is the data with bicuspid aortic stenosis? And here is some work done by my young associate where we actually took 546 patients from different sites, and in a propensity matched analysis, the outcomes were similar between bicuspid aortic stenosis and tricuspid aortic stenosis. Looking at a much larger data set, also from the STS and ACC TVT registry, in almost 2,700 patients with bicuspid aortic stenosis, what we showed was that device success rate was high, almost 96.5%. And conversion to surgery, though higher than tricuspid aortic stenosis, was still less than 1%. So this is actually acceptable. The annulus rupture occurred in 0.3% of patients, and there was a need more frequently for a second valve, but it was still 0.4% compared to 0.2%. And if you look at the 30-day outcomes, the mortality was similar, 2.6 and 2.5% in this propensity-matched cohort. If you look at the stroke rates, they were higher, 2.4% versus 1.6%, and the pacemaker rates were 9.1% compared to 7.5%. So higher statistically because of large numbers, but not that high. And if you look at the outcomes up to 1 year, the outcomes in terms of mortality was very similar between bicuspid aortic stenosis and tricuspid aortic stenosis TAVR procedure. The stroke rates were actually very similar. Though higher at 30 days, they were similar at 12 months. The paravalvular leak rates were somewhat higher, but in fact, they're not very different. If you look between bicuspid and tricuspid aortic stenosis, TAVR at 1 year and 30 days, I actually think that is a limitation of the database. There is no core lab here. These are all site reported. But what was interesting and reassuring was that the mean gradients were actually similar. So you would think that the valve will not expand well and the gradients may not be very good, but that was not the case. And the valve areas were actually surprisingly very similar between bicuspid and tricuspid aortic stenosis. Of course, there are certain limitations. There was no central CT core lab to diagnose even bicuspid anatomy. There was no central adjudication of events, no data on aortopathy, and most importantly, I think the most important thing here is that there was a treatment bias. Did we actually treat patients who were quote-unquote easy bicuspid aortic stenosis patients? So here is a range. I'm just going to show you some examples. This is the easy case, right? We've been treating bicuspid aortic stenosis now for many years, all right? And here is an example of a patient, 60-year-old female. She had other reasons to undergo TAVR. This is not much calcium, type 0. And in fact, here is a valve, a SAPIEN 3 valve with trace paravalvular AI, excellent outcomes here. Here's another patient. So that was the easy. Look at the other, not the other extreme, but a somewhat of a difficult case. Look at this very calcified RAF and also some calcium. And if you look at the fluoroscopy images, you can see that big chunk of calcium as you're doing a balloon dilatation. It seems like it's going to come out, right? But this patient had no surgical alternative. We went ahead and deployed the SAPIEN 3 valve. You see how the valve is sitting eccentrically in the aortic root. There is paravalvular regurgitation, which was moderate. We balloon dilated it further to actually get more expansion. Despite that, there was still some PV leak. So at this point, we decided that rather than take the risk of aortic root rupture, we crossed the PV leak and actually deployed a plug and took care of this situation. So I think we changed our strategy to suit the need to reduce aortic root injury and took care of the situation by putting a PV plug. And as you can see here, there is very little AI left with the deployment of the plug. Here is another case, which is very challenging, right? Look at this case. This person is a 60 or 54-year-old patient. As I recall, we did live during one of the ACC transmissions. This patient's ejection fraction was very poor. It was about 15%, turned down by transplant service, turned down by surgeons. We had to deploy 2 valves during a live transmission to actually get this done. But nonetheless, we got rid of the gradients. You can look at this. The ejection fraction actually improved dramatically. Okay, so you can see this is just immediately post-deployment. The following day, the EF was almost 45%, and this patient was discharged, did quite well. But this is his CT. 2 years later, you can see how the chronic injury in the aortic root has actually led to a pseudoaneurysm and actually caused severe aortic regurgitation. So I think this is something that we have to sort of look out for. So, and here are a number of other cases that we've done recently. So, for example, this is a heavily calcified valve. Once again, this patient didn't have a surgical option. It was difficult, even with a 23 millimeter balloon with an annulus of 600 plus, the balloon would actually watermelon seed. So we used even a smaller balloon, a 20 millimeter balloon, and then undersized with a 26 millimeter SAPIEN 3 Ultra valve, and did manage to get a good result with multiple post-dilatation. So I think that here is the echo, which actually looked pretty good. And here is just yet another case, and yet another case. All of these cases have been done successfully in our lab in the recent times. But we also have to look at what are the outcomes with surgery. And if you look at the outcomes with surgery, they're actually quite spectacular. All right, so I think that we must hold ourselves accountable and actually strive for the similar, if not better outcomes than with surgery. So I would make the argument in the low-risk trials, the 1 and 2 year death, stroke, and rehospitalization rates were very low and lower than surgery. And imaging has actually evolved to help better select suitable anatomical subsets. So, can we use imaging to help us select? Here are different types of anatomies, and what we did was we actually analyzed almost 900 plus CT scans and looked at these anatomical characteristics, and what we showed was that when you have a combination of calcified RAF plus excess leaflet calcium, your mortality is 2.5 times higher at follow-up, at about 2 to 3 year follow-up, than when you actually have none of these features. So I think it is important to anatomically risk stratify. And if you look at 30-day outcomes, they were once again worse or worst in patients who had both calcified RAF and excess leaflet calcium compared to patients when they did not have any of those anatomical features. And what about aortopathy? Patients who had aortopathy actually fared much worse at a 3-year follow-up, but once again, in a multivariate analysis, this was actually not significant. So while in univariate analysis, it was significant, in a multivariate analysis that did not pan out. So the important thing here is to look at CTs while we decide to treat patients with aortic and treat these and selectively pick up favorable anatomies. So the question is, do we really need a randomized trial? I would make the argument that we actually do need a randomized clinical trial, because unless we actually do randomized clinical trial, I don't think that bicuspid aortic stenosis TAVR will be fully embraced by a lot of referring cardiologists and by a lot of surgeons, and I think for a reasonable reason. So should we imply, in low-risk patients, is TAVR equal to SAVR? We've been doing this in intermediate and high-risk patients. I don't think we should assume that or infer that. I think we must do a randomized clinical trial. Now, you and I will continue to do these TAVR procedures till a randomized clinical trial is done, and perhaps more experience will accumulate. But nonetheless, I think there are some practical considerations. So I think CT stratification is very important. You have to some degree undersize, not by a whole size of valve, but I think you need to be cognizant about that. Positioning is harder. There is a greater risk of aortic root injury. So I think it is best to do this with TEE, I believe, rather than just with conscious sedation. And predilatation is a good idea because it avoids difficult crossings. These valves are often heavily calcified. And also it can avoid injury to the dilated aortopathic situations. And I think post-dilatation and rarely repeat valve-in-valve may be needed, though I have to say with the newer generation devices, that doesn't seem to be as much. So I hope that I have shown you some of the data that is available, some clinical examples, but I do still want to make the argument that we do need a randomized trial. Thank you.